All right, let's try this out. Let's see about starting a lecture. All right. We are set to talk about Chapter 7 of Faber for your next unit in class. This unit is all about scatter control. You guys have already had a little bit of experience with your scatter control lab that Leah did with you guys while Mrs. Garner and I were in Atlanta. So hopefully, can't see me, my fingers are crossed. This is not all foreign material to you. As always, we start with objectives, and just like always, I am 97.5% positive that you all can read. So I'm not going to read them to you, but I will tell you that you need to make sure that at the end of this lecture and some of the math worksheets we're going to work on and some different things, you want to revisit your objectives and make sure that you can do what they say. For example, the next to last one on here says describe the purpose of a radiographic grid. So what does that tell you? It tells you that whenever it comes exam time, which will still come, coronavirus or not, that you need to be able to explain what grids do, how they do it, what different types there are, all that kind of thing. So these are basically your study guide for this unit. We'll do some math. I'm going to figure out a way. I haven't figured it out yet, but I'm working on it to be able to show you guys some math problems. There is a whiteboard feature on this Collaborate thing that I'm using. And if push comes to shove, I can do some chicken scratch kind of situation on here, but we'll see. We'll just see about that. All right. Hopefully you guys can see what I'm seeing. That is the plan, but we'll see. I'm on slide number 5. The numbers are at the top right for your reference. Basically, scatter radiation is unwanted density added to our images. It's formed in the patient through the Compton interaction. I found a good video for you guys to review the Compton effect. And it was on YouTube, and it's only like 5 minutes long, which is pretty much my favorite length of video for anything, because I don't have the attention span for much more than that. But anyways, scatter radiation is that radiation that underwent Compton effect inside the patient, interacted with the outer cell electron, kicked that electron out, and the photon that interacted with that electron has lost some energy, so it has changed direction. It's not going from whence it first came, and it's not going in the same direction that it was. Recall also that as much as the direction changes tells you how much energy was lost. So if it scattered a whole bunch, it lost a whole bunch of energy. If it just barely scattered, it didn't lose a whole lot of energy. This slide says that scatter radiation is detrimental to radiographic quality because it adds unwanted exposure, just aka fog, to the image without adding any pertinent information. So that scatter does get out, and it does get to the image receptor. It can also get to us, which is no bueno also, right? But it can add to the image, but it's not useful information. When we use the example of shining a light on your hand, say, to look at your shadow and see if your shadow represents what a hand actually looks like, scatter would be like if you had something diverting the light or the shadow elsewhere. Basically is what scatter would be doing there. Since it does create an overall film darkening or an image darkening, it reduces image contrast. With decreased contrast, recall contrast is your differences in your densities. So you're not going to have those white whites and those black blacks. Everything gets overall grayer. So we say the image is fogged. And that's really what it looks like. It looks like when you look outside your window in the morning and it's foggy outside. Everything just looks gray and washed out and you can't make things out. That's what scatter does. It says increased scatter radiation is either produced within the patient or high energy scatter exits the patient. Okay, yeah. It either exits or it gets absorbed within the patient. Yeah. It's either produced within the patient or higher energy scatter exiting the patient. Whatever, it's bad. Scatter's bad. Okay, that's what you need to know about that. Let's move on. What slide am I on? Number 6. Increase in the volume of tissue irradiated results in the increase of scatter production. So when we talk about what increases scatter, there are two main things with some little subheadings, okay? The first main thing is volume of tissue irradiated. When you have an increase in the volume of tissue, you're going to have an increase in scatter radiation. So think about what that means. Recall from physics, because I know you all remember that well, that volume is basically a measure of like length times width times depth. It's how much space something takes up in 3 dimensions. So that being said, thinking about your patient and thinking about what we're talking about here, that means that you're either going to be dealing with patient thicknesses that are increased. If you're increasing the volume, it would be like a thicker part compared to another part, or you can be thinking about an increase in the area that is irradiated. When we talk about that, we're thinking about your field size, thinking about your collimation. So if you have your collimation wide open for something, you're going to have an increase in scatter. Or if you're x-raying someone's leg that's 10 centimeters thick versus somebody whose leg is 20 centimeters thick, you're going to have an increase in scatter radiation. So that's the volume piece of the thing that increases the things, that increase scatter production. The thing number 2 is your X-ray energy. Using a higher KVP technique is going to increase the production of scatter inside the patient. The higher the energy is, I don't want to bog you down with this too much, but basically the higher the energy is, the more likely the scatter is to continue going in a straight direction. Remember we said that when you have the Compton interaction, the amount that it's deflected, the angle that it's deflected tells you how much energy it lost. So if you have something with a high energy and it doesn't lose much energy to that outer cell electron, it is more likely that that X-ray photon is then going to exit the patient in a straight-ish way, which means it's going to hit the image receptor. So the higher your KVP is, the higher your probability of scatter is, and the increased volume of tissue is going to have an increase in your production of scatter inside the patient also. All right. Where are we at? Yep, okay. So are these things good? No, they're not good. I think my dog's chewing on something. I'm not really sure. Sorry about that. No, these are not good things to happen. We don't want to have scatter. We don't want to have decreased visibility of our structures, right? Because remember, contrast and brightness fall under the visibility of structures whenever we talk about radiographic quality. So what are we going to do about it? Throw our hands up in the air and be like, I don't know. No, man, we got things we can do. The number one thing that we can do as techs is to restrict the field size. We can't necessarily control how thick our patients are. Wouldn't it be cool if we could, though, right? But we can't really control the patient thickness. In some situations, you could use a compression device. That's what your textbooks will tell you. I will tell you personally, I have never seen anyone compress a patient's parts. Don't compress patients' parts. It would be awkward to have that conversation. So we're not going to do that. So we're going to go with beam restriction. There are different beam restricting devices. There's 4 types. I don't remember right off. We'll find out in about 2 slides. But there's different ways we can restrict the beam. Obviously, you guys are most aware of the collimator box. It's called a variable aperture diaphragm. Sounds fancy, but it's just the collimator box that you guys are used to using. There are some other ones we'll talk about in a second. We also use grids. You guys have learned a little bit about grids in RAD 110 and then with your scatter lab. Grids are things, they used to be way back in the day before infection control became what it was. They were actually big things of wood with lead strips in between, and the lead just captures the scatter radiation, the stuff that's not going in a straight line, and keeps it from getting to the image receptor. And they improve the image quality by absorbing that scatter, but they do create a need for increased technique. So that's why we don't use grids for things like hand x-rays, right? They're not thick, they're not a huge field size. And if you used a grid, you'd have to increase your MAS significantly. So it's just not worth it. Remember from RAD 110 that your rules for using grids are for parts that are greater than 10 centimeters in thickness, which is roughly 2 inches, this much, from what I always think anyways. And then also, what's the other rule? Oh, greater than 60 kVp. So if you're using a high kVp on a thick part, you're going to want to put a grid on there. All right, slide 8, beam restriction. Beam restriction is basically working on, remember we said there's 2 principles to scatter control. You can change your volume of tissue, or you can change your kVp. If you're leaving your kVp the same, volume of tissue is your thing. And again, you can't control the thickness, so you can control the area. And that's what beam restriction does. It's going to reduce your patient exposure. I'll talk about that in a minute. Sorry. Your patient exposure is going to be reduced because you're physically not putting x-rays on as much area. A note about beam restriction or collimation under here, it's got collimation. It says increasing collimation means decreasing the field size, and decreasing collimation means increasing field size. That can be confusing to students sometimes. Historically, when I have taught this class, students have had a hard time kind of wrapping their head around what that sounds like and what it means. So make sure that you really take your time and read these things whenever it is test time. Because if I say increase collimation, remember collimation means to make it smaller. So if I'm increasing, making it smaller, it's getting littler. And if I'm decreasing the making it smaller, I'm actually making it bigger. So if you have an increase in collimation, you are going to have a decrease in your field size. And if you have a decrease in your collimation, you're going to have an increase in your field size. I cannot emphasize that enough because students mess it up so bad on exams. And I love y'all and I don't want you to mess it up. So make sure that you can take your time and decipher those when your test time rolls around, okay? What do we got here? Less scatter radiation is produced within the patient. Less scatter reaches the IR. But when you do collimate, because not as many photons are getting to the patient, you do have to increase your technique. We used to have math for this. There was a collimation factor, and like if you went from a 14 by 17 to a 10 by 12 or something, you had to multiply your technique by like 1 1/4 or some crap. You guys don't have to know that, okay? So don't freak out about it. It's okay. But just be aware that when you go from a larger area to a smaller area, you are decreasing your exposure to the IR. When you really think about it, if you're having like, say, 1 million photons, but you're only letting them out of an area this big versus this big, it's going to be a decrease in the number of photons that hit the image receptor, right? So I hope you guys can see me when I'm doing my hands, because I don't know. We'll see. Anyways, field size. If you use a smaller field size, you have less exposure to your IR. Sorry, brain fart. Also, I will tell you that the way that that works is because, yes, you're making the same number of photons, but the thing that the collimator shutters that you guys are moving when you're turning those knobs on your collimator box, they're lead. So they are getting in the way and they're stopping those photons from exiting, passing through the collimator box. So that's how that works. If they, here's a review question. If they are lead, which they are, it's not made up, and they are stopping X-ray photons from exiting the tube, what interaction in matter do you think is happening there? Think about it. I feel like Dora the Explorer right now, blinking and staring at you guys. It's the photoelectric effect. I have brain fart again. Photoelectric effect. It's complete absorption of the X-ray photons. So if they're absorbed, they're not getting out. There's not as many. There's not as much exposure to the IR. Whew, okay. Types of beam restriction. What we got? 3 main types. Carla, seriously? Sorry. 3 main types of beam restriction. The first one is the simplest of the beam restrictors. It's an aperture diaphragm. It is a fancy name for a piece of lead, like a flat piece of lead with a hole cut in the middle. That's it. I don't really have much else to say about that. Imagine you took a sheet of paper, cut a circle in the middle, and then you shined a light through it. Not all the light gets through. That's what happens with an aperture diaphragm. You guys probably never see these used. I think they use them in dental x-ray, but I've never seen one used in regular x-ray. Just know what it is and the key points, which is basically is the simplest. You got cones and cylinders. Cones and cylinders look like what they say. Obviously, the cone looks like a cone, which you can think of. My favorite cone is, of course, the cone of shame for your dog when they get fixed or whatever and they can't lick. So they have that cone, or the other cone is an ice cream cone. I'm lactose intolerant, so that one doesn't really get to me. Those are cones. Your cylinder is like a long tube. It's like a piece of pipe that slides on the front of the collimator box. You guys may have seen these ones in clinical. We used to use them a lot, especially for like sinus x-rays. Trying to think of some other, like cross-table hip x-rays. They're excellent for cleaning up the scatter that gets produced in that thick body part. But most people don't really use them anymore. If I had to guess, you guys have seen them and dusted them, but probably never used them. And then, of course, the collimator box. You guys are familiar with that one. And I got a picture here. Over here on the right-hand side, we've got the collimator has lead shutters that you can change to change the shape of the beam that's going to actually exit. There are collimators that can be changed. What the heck has this dog got? Bob, stop it! You're killing me, son. I am so sorry. Collimators. There are some that have more than just 2 sets of lead shutters. So the kind that you guys use, you have like 2 shutters this way and then 2 shutters like this way, right? To make like a rectangle or a square or whatever. But they do make some that have more pieces of lead in them, and they can be changed to make like an octagon shape or whatever else. But just be aware of what they are. Don't worry about all that. I'm not going to ask you about octagonal collimators. Seems ridiculous. I don't have anything else to say about these. Oh, quick, before I move on. Over here, the cylinder and the cone. I'm going to Dora Explorer you guys again and ask you, which one of these do you think cleans up the most scatter? Did you think about it? Or are you just waiting on me? All right. Now that you've had a second to think about it, it is the cylinder. If you think about it, on the most basic level, it's a matter of size. That's right. I said it, and it's on a recording. Size matters. Whenever we're talking about our beam restriction, whenever you're comparing your cylinder and your cone, look at how much smaller the end of that cylinder is compared to the end of that cone. How much are you really restricting, right? Not near as much. So the cylinder is definitely going to be your beam restricting device that provides the most scatter cleanup. Okay, Now I can move along. Grids, fun stuff. All right, thin lead strips, radiolucent interspace material. Radiolucent, think about glass. If something is lucent, you can get light through it, right? And pass through it. On the opposite side of that, you have something called radiopacity, or something that could be radiopaque. Radiopaque means the opposite of radiolucent. So instead of it letting X-rays pass through, something that is radiopaque does not allow X-rays to pass through. It's going to block the X-rays. Same thing if you were talking about like a piece of glass that was opaque. It would be something that you could not clearly see light or color or whatever through. Okay, so the interspace material, the stuff that is not the lead in the grid, we want to be able to let those X-rays through, because those are the good X-rays that are going straight. They're passing through the matter and giving us a good representation of what is going on in there. So we want those. So we want those to get through. The lead strips are what's stopping the guys that are going all crooked-eyed and coming from the wrong angle and all that stuff. There are different ways that you can describe grids. They can be described based on grid frequency. Excuse me. Grid frequency refers to the number of lines per inch or per unit of measure of length. It could be inch, could be centimeters, like how many actual strips there are crammed in that space. And then your grid ratio is basically what it says. It's a ratio of the height of the grid lead strips divided by the distance of the interface material between those lead strips. So it's a relationship. It's a ratio, just like I said. Like I said, like it said. It's the height compared to the distance between them. Grids can either be linear or crossed/crosshatched. On an exam, I would probably just say crossed grid, but crossed or crosshatch mean the same thing. And that's kind of like that basket weave pattern, like it looks like over there on the right hand side of this PowerPoint. These are less common compared to linear grids. Linear grids, when you think about grid construction, you think about when you use grids. You know, a lot of times that we use grids, we're using grids, stationary grids, that's what these are. We're using them on people, we're doing portable x-rays. If they can come to the department and be x-rayed at a wall bucky or in the table bucky or something like that, you have more room for error. But when you're doing portable exams, you don't want to have something that you have to be exactly perfect with, because you can't be. Portables are done under less than perfect circumstances, right? So linear grids are more often what we are using in our applications in X-ray that you guys are doing when you take and go do a portable or something like that. Linear grids, crosshatched. Trying to make sure I'm not forgetting anything. I probably am, but I can't remember. All right, grid focus. So linear grids can be focused. Most grids are focused grids, because recall that your X-ray beam is coming out of the tube in a divergent fashion. What the hell does that mean, Janime? That means it's coming from a point and it's going further away from itself like this. It's spreading out as it comes out. That's why the further you get away, the less intense your X-ray beam is, because it's spreading out. That's what divergence is. It's going in different directions. So when you're looking at your grid, your X-ray beam is coming out as a point source. Remember, your spot on your anode is tiny. It's like maybe 1 millimeter. So that's 1/10 of a centimeter, just small, right? You guys hopefully remember that a millimeter is 1/10 of a centimeter. Oh, anyways, grid focus. Because your X-ray beam is coming out of the tube in a divergent fashion, your grid is constructed to match that. the grid strips, instead of being straight up and down, are slightly kicked in like so to match that angle of divergence of the beam. That being said, with a focus grid, you have a, like, what I would call a sweet spot where this is more ideal. Come on, notifications. I'm trying to do a lesson. We have a sweet spot where our ideal range is. So with a focus grid, you have a place where your X-ray tube should be in relation to the grid to allow the optimal amount of X-rays to actually pass through. So if you had your X-ray tube much further away from your grid or much closer than your grid, that angle of divergence is going to be off. And if the angle is off, then you're not going to get an optimal X-ray, right? What is this dog doing? Sorry. That range of distances is called the focal range. Within the focal range, there is generally a convergent line where if you drew an imaginary line from all those grid lines and they would come to a point, and that is your convergent line or your convergent point, that one place. But your range could be any SID greater than or less than that where the grid would still work. So thinking about that, what do you think the focal range for most of the grids that you guys use on the portable machines is? Would you say it would make sense if they bought grids that were made to be focused between 40 and 72 inches? Yeah. Because if you're, first of all, that's what we use for like everything. But if you're beyond that, if you are at a SID of, I don't know, 100 inches, that's really freaking far away and nobody's doing x-rays out there. On the flip side, if you were trying to do an x-ray with an SID of like 20 inches, remember your collimator box and stuff takes up about 10 inches. So like that's not happening either. So most of this information, well, let me rephrase. All of this information has to be on the grid somewhere. When the grids come from the manufacturer, they have a sticker on the back side that tells you your grid frequency, your grid ratio, your focal range, all that jazz. So when you guys are at clinical, hopefully soon, I want you to take a minute if you can and look at the grid and see if it tells you this information and just make note of it. You know, you might not have thought about it before, but it is there. There is a sweet spot, like I said, so to speak, where most grids are have a focal range of 40 to 72 because they want you to be able to use them for everything. They don't want to buy one that has a focal spot of or a focal point of 40 inches and a different one at 72, and you have to change out the grid depending on what you're doing. I know they have that in some rooms at Moore. What is it? In the ED, the GE room has that you have to change out the grid. This is also the reason those of you who have been to Rockingham, that main x-ray room that they use at RMH, they don't change, they don't have a grid that changes to a 40-inch grid from what I've been told. And that is why they use the same grid and they do all their exams at 72 inches in the Walbucky because they don't have a 40-inch grid for the Walbucky. So that's that about grid focus. All right, reciprocating grids. So I told you stationary grids are what we use when we do portable exams. You put it on the front of your cassette, your image receptor, your DR plate, whatever you want to call it. You put it on the front of there, put it behind your patient, take your x-ray, it's all good in the hood. Those are stationary grids. What are you doing, dog? Oh my God. Your reciprocating grids are basically very similar in construction as far as your inner space material and your grid is lead strips to stop the scatter radiation. The difference is that they move. You're not going to believe this. They reciprocate. That means they move back and forth. If any of you have ever used a reciprocating saw, it's the one that does like this. That's a reciprocal saw. Your reciprocating grids do the same thing. Those of you who have been to Central Carolina Hospital, and you've heard that wall bucky, especially in room 2, the most commonly used room, it sounds like it's going to rattle the patient's teeth out because it's old. But that is the bucky reciprocating during the exposure. So that's what you're hearing. Whenever you start to mash down your exposure button and you hear it, it's your grid actually shaking in front of your image receptor before you make the exposure. And what that does is it uses the principle of motion. Remember, we talked about motion last unit. We talked about how it makes it where you can't see the anatomy as well. Well, motion works to our advantage in this situation because it makes it to where you don't see the grid lines. You guys don't really get to appreciate grid lines like we did with film. Whenever we would take an x-ray, you could actually look at the film and see the really small lines all over the image, and that would let you could look at a film and tell whether or not it had been used, if the x-ray tech had used a grid or not, because you could see the grid lines. But you guys don't get to see that now. There's software that suppresses the grid lines and all that jazz, so you guys don't have to worry about that. But back in my day, that was a big deal because the grid lines could obstruct things. So that's why they have the reciprocating grid. Whenever you guys are doing things in the bucky, you are using grids, whether you realize it or not. They're just built in and they shake during the exposure. They were now I'm going to forget. I'm already recording this, so I'm stuck with it. But they were the reciprocating part of the grid, I'm pretty positive, was invented by Hollis Potter, and then Gustav Bucky invented the grid. I'm pretty sure. It's probably in your book, and I probably just said it backwards, but that's pretty close to what it's supposed to be. But anyways, that's why we call it a bucky, because it was named after these guys. I feel like I rambled a lot on that one, but that's okay. All right. On those stationary grids, the grids that you guys use when you do portables, they can either be marked as being a long dimension or short dimension. Why does it matter? Well, actually, let's talk about what that means first. Okay, so if a grid is a short dimension grid, the fact that it says short is describing the length of the grid lines. That's how I think of it, okay? So if you think about the length of the grid lines, and let's pretend that these images that are shown on your screen right now are 2 different grids, right? You've got the one on the top, it says it's a short dimension grid, right? But let's pretend they're both 14 by 17s. So if they were both 14 by 17 grids, if this is 14 inches up and down, but this is 17 inches side to side, then these lines, obviously, they are running that direction. The lines themselves, the strips of lead, are shorter, okay? So that's how I remember it. Short dimension means that the lead strips are shorter in length. Long dimension means the opposite. Long dimension means that they are running with the long axis of the grid. So in this example, your lead strips in the long dimension grid would be 17 inches long, roughly, for that. Can I help you, sir? Okay. Why does this matter? Okay, this matters because whenever you go do a portable exam and you are, let's say you have one of those patients who is extremely kyphotic. Okay, so they're super hunched over, and you are trying to line up to their sternum, because that's what you're supposed to do for an AP stretcher chest, right? You're supposed to enter the chest at the level of T7 with a perpendicular central ray, but your grid behind that person has come forward because of how they have come forward. With a short dimension grid, you would be safe because your your lead strips are running up and down. So if you're off up and down with your centering, you're safe. Now, same situation. If you have a long dimension grid, and imagine like I've got, I don't know if you guys can see me, but I've got my hand like across my chest, like fingers going toward one shoulder, palm going toward the other shoulder, right? If you imagine the grid strips are your fingers, and you've got this same situation where the person's anatomy and the grid don't match, if you have the lines tilted one way or the other, or your X-ray beam coming and the lines and the angles don't match up, you're going to get grid cut off. So I think about like grid lines. When I think of grid lines and what they're doing, I like to think about blinds. I know that sounds kind of crazy, right? But I think about like long dimension grid would be kind of like, in this example, would be like mini blinds or like regular blinds that most people have in their house. Where the short dimension in this image on slide number 16, those would be more like those vertical blinds that most people don't have in their house. My mom used to have some like this. And I think there's some rooms on campus that have them, but for the most part, most blinds are like this example of the long dimension grid here in this picture. So if you had sunlight coming directly from the side of your window, you're imagining some blinds, you got sunlight coming, like say right at sunrise. You don't want to have your blinds open if you're trying to sleep in, right? You want to have them closed so that stuff doesn't get through. Well, the opposite is true for X-rays and the use of grids. For grids, we want all of the useful X-rays to get through. We're not really trying to block much out. We're just trying to block the stuff that's gone awry and is coming from the wrong way. So you want to make sure that you have everything lined up as much as possible so that you don't get grid cut off. I'm sure there will be questions about that, but we'll see. What in the heck? Come here. Come here. Oh my God. Come here. Oh. Oh. What the hell? Okay. 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 All right. Whoa. Whoa. I got Bob here to possibly help with this lesson. Oh my God. Sit down. Sit down. You are ridiculous. Okay. Okay. All right. That's enough. What the hell is happening right now? Okay. Now, we said earlier that whenever you use a grid, you clean up the scatter. Well, if scatter radiation gets to the image receptor, and we have to have so much radiation to the image receptor to have an optimal image, whether it's scatter or not scatter or whatever, if we cut that scatter out, then all of a sudden we don't have enough X-rays, or we don't have the same amount that we thought we were going to have. All right, buddy, you gotta go. You're killing me. Oh, God. Oh, God. Okay, so we have to do math. I know it's all of your favorite, especially Carmen. I'm thinking of you right now, boo. There's math to convert and figure out exactly how much X-ray you need to add, depending on what kind of grid you're using. We will only do grid conversions with linear grids. There are different conversion factors for crossed or crosshatch grids, and we're not doing them. They vary by manufacturer, and the ART will not test you. Sorry, I had to think about the right word. The ART will not test you guys on different manufacturer-specific things. So it's not going to be on your registry, basically. So I'm not going to teach it to you. So we will do grid conversion factors. I pulled this information on the next slide with the different grid conversion ratios. I can't remember if this came directly out of your book or if I pulled this one from Bushong, but they're both in there. I will also tell you on occasion you might see some practice problems that might say a 4-to-1 grid. That would be like the lowest grid ratio we would ever use. But that would lump in with the 5-to-1 grid with a grid conversion factor of 2. Looking at these things, you can see that if you don't use a grid, your technique stays the same, right? That's basically what your Bucky factor or your grid correction factor is telling you. It's telling you how much more or less or whatever you need to be using to make your x-ray still turn out. So if you go from no grid to no grid, you don't have to make any changes. But if you go from using no grid to using a 16-to-1 grid, you need to use 6 times as much x-ray. I would say the most common grid ratios are going to be like your 10-to-1, probably 10-to-1. I think that, trying to remember the last time I looked at grids at clinical, I feel like some sites have 12-to-1 and some sites have 8-to-1. So that's kind of like an average. I know at Moore Regional, they used to use the 16-to-1 for x-rays for the cross-table lateral spines that they did after myelogram injections, because they're really trying to optimize the contrast. They really want to get all the scatter they can. They recognize that the patient's going to have a high dose, but it's only for one projection. It's just one cross-table spine. So they don't, it sounds terrible, they don't really care if it's a high exposure because it's only one of them. It's not like they're doing a whole series. And the patient at that point has already had fluoro, so it's like, what's one more x-ray, right? So as you increase your grid ratio, you have to increase your technique, and your grid correction factor tells you that. I will tell you that you have to know these. You will have to know them from now until forever. You'll have them on every clinical exam that you ever have. For me, you'll have at least one grid correction factor question. So learn them, love them, live them, commit them to memory. These are important, okay? I'm going backwards. I'm back on 17 now. Your grid conversion equation. This is shown 2 different ways. This is 2 equations. Imagine that there's like a line between these 2 equations, but they basically say the same thing. I always do my math problems with this equation on the bottom. Your MAS1 over MAS2 is equal to your grid correction factor 1 over grid correction factor 2. Because you know me, I'm a creature of habit. I like to do them the same way every single time. And then if you ever get confused when you're setting up your equations, remember you have to use common sense, which I know is not always common for everybody. But if you're increasing your ratio, you're going to have to increase your MAS. So they are directly proportional. Don't forget that, directly proportional. So if you're directly proportional, that means that your MAS1 should be across from the equal sign to your grid correction factor 1, and vice versa. With your MAS2, it should be directly across from them. They're directly proportional. And if you increase your grid correction factor, your MAS should increase. If you decrease your grid correction factor, your MAS should decrease also. So keep those in mind. I'll have some practice math problems. Sometime we'll get to do those together whenever the state of North Carolina lets us. But until then, I'll probably figure out a way to video record myself doing them, because Lord knows this is enjoyable. So we'll do some practice math with those. Again, I want to remind you, you will have grid conversions on every clinical exam from now until the time you graduate. So do not purge this information from your memory. All right, are grids all cupcakes and puppy dogs? No, puppy dogs. I'm tired of this one at my house right now. It's not even a happy thing. Usually cupcakes and puppy dogs is what I say about happy stuff, but this is just sad, sad, sad. Anyways, everything is not fantastic. It's not all peachy keen. It's not all whatever you want to call it. With grids, things can go wrong. Remember, I told you if you have your angles off, you can have cutoff. You can have This can be, there's 4 different types of grid cutoff, and they're basically named on the reason that the cutoff happened. So upside down focused grid cutoff. This one is the easiest to spot because only the center of your image receptor will have exposure. This also would be really hard to actually do in real life unless, well, unless you're stupid. I don't know how you could have a grid upside down on a cassette, but I guess it's a thing. I don't know. So upside down grid cutoff, you only have exposure at the center, and who the hell? I mean, really, nobody can do that. Off level grid cutoff. This one is going to be your most common cause of grid cutoff. This one is going to be the most common cause of grid cutoff, and this one is going to be the most common cause of grid cutoff. Okay, off-level grids are common. It happens. You think that your patient is laying flat in the bed, you put the grid under them, you think it's all good in the hood, you make your exposure, it's freaking not. It happens a lot. Again, when you think about when we use grids and the fact that you're using them in suboptimal conditions, stuff's going to happen, and most likely it's going to be off-level grid cutoff. Off-center grid cutoff, whenever you are thinking about the way that the beam is diverging and the way that your grid is focused, if you're centered to one side more than another, you're going to have cutoff for that situation. And then last but not least, you got off focus grid cutoff, and that happens whenever you don't have the right distance for your grid. We talked about that. Again, you're either going to have too much divergence or not enough divergence to match those focused grid lines. Here's some pictures. I only have pictures of upside down focused grid cutoff because it's very easy to tell what that one is. And then with this guy, you can tell over on the right-hand side with the radiograph demonstrating off-center grid cutoff, you can tell because there's more exposure to one side than the other. But again, I would be most concerned with off-level because that is the most common. And in off-level grid cutoff, this is basically what happens. Your grid is not level. This is over here on the left-hand side of the slide. In case you guys don't see my mouse, I'm not sure if you can see my mouse. But the grid lines are not matched up with the divergence of the beam, and as such, they restrict the access of X-rays to the image receptor, so you don't get as many. For you guys, whenever you guys had your lab with Leah, I hope that you were able to see your images that have grid cutoff won't necessarily look exactly like these because of digital. You can see how you can see these lines. Remember I told you with film we could see grid lines on our images. You guys, for you, it'll show up as quantum model because it's just the detector trying to make sense of not enough information there. I will probably not have radiographs that ask about what type of grid cutoff it is. I could have some word problems that would, you know, like, who do I want to pick on today? Oh, my favorite to pick on usually is Jerica, so I'll stick with that. So Jerica goes to do a portable abdomen. Patient is hyperstenic. She's trying to do this x-ray. She has quantum model on one side of her image, but the other side looks okay. What do you think happened? It's probably off-level grid cutoff. Not just because it's the most common kind, but when you think about what's happening, if Jerica's going to do a portable abdomen and the patient is a very large patient, for one, you can't see exactly where the grid is up underneath your patient. Sometimes you can't feel up underneath the patient. And then, of course, with our hyperstenic patients, you know, sometimes they look straight when you go to x-ray them, but they're in the inside of their bodies is not straight. All of that extra soft tissue tends to go with gravity and look nice and flat whenever their spine can be twisted all kind of ways or whatever. So you could have some scenarios like that, but probably not any x-rays or images that ask about grid cutoff, because that's just too much. I have one slide on here about the Mora effect. Ms. Garner will talk to you more about this in DR class, RAD 1. What the crap is that class? 122 in the summer. Mora effect is something that can happen when your grid lines match the way that a CR reader reads a CR cassette. And basically what happens is a bunch of lines show up because they don't get exposed and they don't get read in the same way. It makes it kind of look like zebra stripes, depending on the direction. But Ms. Garner will talk to you guys about that in digital class. So just be aware of what it is and that it only happens with computed radiography. I think I'm getting close to the end. I'm very close to the end. Okay. This is taking a lot longer than I thought. As per normal operating conditions, I have gone out of order. I told you about the rules for grids before I started, and here they are again. So you always want to use grids whenever the anatomic part is 10 centimeters or thicker, when you're using a KVP of 60 or greater. And as you increase your grid ratio, you're going to increase your scatter, but you are, increase your scatter absorption. That's an important thing to add. But you're also going to increase your patient dose, because the x-rays are not being stopped before they get to the patient, but rather after. So they've already interacted with the person before the grid gets involved. And you have that increase in MAS because of the scatter control. So you have all those factors. Also, you have an increased potential for grid cutoff with the use of higher ratio grids. Then there's a little box here that I stole from your book. It says that your typical grid is linear instead of crossed. I already told you that, so thank goodness. Is focused instead of parallel. Also pretty sure I told you that. If I didn't, I meant to. Has a mid-range ratio of like 8 to 12 to 1. You don't want to have a 16 to 1 for everything, because you don't need that much scatter cleanup, and you don't need to give 6 times as much radiation for every single exam. But you also don't want to use like a 4 to 1 or 5 to 1 grid for everything, because it's not as effective. So most places will have something that has a middle range. Some places will have different ones for different things. Like I said, more regional for sure used to have 10 or 12 to 1 for like regular stuff. They used 8 to 1 for abdomens, and then they used that 16 to 1 for their cross table lateral spines following myelogram injections. It just depends on your application and or your site. I know at Central Carolina we have the same grids for everything because budgets are an issue. At more regional, the Taj Mahal of x-rays, of our x-ray rotations anyways, they have different ones. They have options. So just be aware of those things. Last but not least, the other way, there is another way that we can offset scatter. This one is not commonly used. I've only ever used it in a trauma situation where I got like excited because there was trauma, and I went running toward the ER with no grid, and they said, "We want a cross-table lateral skull." And I was like, oh, okay. So in that kind of a situation, when you don't have a grid but you need a grid, you can use what's called the air gap technique. An air gap technique is basically you're just putting space. You're using an increased OID, which of course is going to increase your magnification, because remember, you're sit over your sod. But it is going to have a decrease in spatial resolution. However, it will offset the effects of the scatter radiation. Because what it does is it gives space for the scatter to be deflected before it hits the image receptor. So you can see from the diagram here, the scatter happens, and then instead of going straight and getting to the image receptor, it has space to miss it altogether. It's not an ideal situation, but it works in a pinch. All right, so we said to reduce scatter, we can reduce the volume of tissue being irradiated. Volume of tissue is made up of the thickness and the area exposed. We can't change the thickness, we can change the area. So collimation, beam restrictors, those kind of things. We can also mitigate, or we can reduce the formation of scatter altogether by using a lower energy X-ray beam. So decreasing your KVP is going to decrease the amount of scatter produced. We can also offset or mitigate what happens after the production of scatter with the use of grids. We talked about grids, and we can reduce scatter by using something called the air gap technique. Again, not an ideal, but it works. The only thing that I really wanted to touch on before I wrap this up was two things. The very last page, well, the next to last page in your book, talks about scatter control and digital imaging. The takeaway there, digital image receptors are much more sensitive to the effects of scatter radiation. So you might see them. I like to give the example when you do like a lateral lumbar spine and you have collimated it in, but you still see like an outline of the patient's body kind of outside of your collimation. Again, this is hard to demonstrate without a picture up here or my hands to show you or a crappy drawing to draw you on the whiteboard. But whenever you have that situation where you have collimated down to the spine, but you can still see the outline of their belly, their behind, their soft tissue, those are the effects of scatter. That's scatter radiation. That you collimated your beam to, say, like a 7-inch wide area, but on the image receptor, you've got 12 or more inches of stuff that's actually showing anatomy. It's because of the work of scatter, and digital imaging is more sensitive to the effects of scatter. The next thing that is here at the very end of the chapter talks about shielding accessories. And the fact that you can place a lead mat behind your patient, this is especially in that lateral lumbar spine situation that we just talked about. You can put a piece of lead behind them and it cleans up that scatter. So obviously, if you clean up the scatter, what's going to happen to the visibility of your image? It's going to be increased. It's going to be better. So that's always a good idea. Also, you can do that in different projections, but it's most commonly utilized in the lateral lumbar spine or the lateral L5S1 projection. It's just important to make sure that you don't put the lead so close to the patient that you obscure your anatomy or get within the area that's going to be exposed, because that will mess up your numbers in your computer and all that stuff. So now I think that I have finished this experiment in online instruction. I have some more information about scatter, but I just wanted to get this out to you guys as soon as possible because I know that you guys have kind of just been in limbo with this whole corona situation. It has been a learning experience for all of us, and we'll make it through. I just want you to know that Mrs. Garner and I are here. We will do everything we can to make this situation as, what's the word? I don't know. As less crappy as possible. We just have to go with what our administration and the state, the main office, the North Carolina Community College System office, and go with what they tell us to do. It's changing every minute. But I wanted to have something out there for you guys to be able to look over things and not lose your skills and your knowledge before you guys are able to come back. I hope that this helps. Please email me if you have questions. I will talk to you soon.